So the topic of lecture is pulpitis, and it outlines such questions. First of all, anatomy, histology, and functions of pulp, definition of term pulpitis, epidemiology of disease, reasons of pulpitis, pathogenesis of pulpitis, clinical manifestations of pulpitis, complaints and symptoms, diagnosis and differential diagnosis of various types of pulpitis. Left untreated, dental caries usually destroy most of the tooth and invade the dental pulp, leading to an inflammation of the pulp, that is pulpitis, and as a result, significant pain can occur. Pulpitis can progress to pulp necrosis with bacterial invasion of the alveolar bone. So pulpitis is mainly caused by bacterial infection, which itself is a secondary development of caries tooth decay, and it manifests itself in the form of toothache. It is obvious to refresh in your mind the knowledge about anatomy and histology of a pulp for clearly understanding of this disease. So, what is pulp? It is connective, soft connective vascular tissue that contains blood vessels, nerves, and connective tissue, and thus it provides the supply of nutrients to the tooth tissues, such as dentine and enamel. From the point of anatomy, the pulp occupies the center of the tooth cavity of the pulp chamber. The shape of the pulp approximately follows the shape of the outer surface of the tooth crown. And it is obvious that under every cusp there is a pulp horn. The shape and number of root canals can vary considerably depending from the group of teeth. At the apex of each root is a foramen or foramina through which blood vessels, nerves, lymphatic vessels can pass. And histology. So the pulp is a part of dentine pulp complex. The common name of it is endodontium. The vitality of the dentine pulp complex, both during health and after injury, depends on pulp cell activity and the signaling processes that regulate the cell's behavior. Cells found in the dental pulp include fibroblasts, the principal cell, odontoblasts, defense cells such as histiocytes, macrophages, granulocytes, mast cells, and plasma cells, and the nerve plexus of Rajkov. It is located central to the cell-rich zone. It monitors painful sensations. Odontoblasts can be found at the periphery of the pulp. At the time of eruption, a cell-free zone known as the basal layer of veil often develops beneath the odontoblasts. Deep to this zone can be found a cell-rich zone, which contains a plexus of capillaries and nerves. Fibroblast cells are very numerous within the pulp and have function to produce collagen. Defense cells, histiocytes, or fixed macrophages are the main defense cells found within the pulp. When the pulp is inflamed, histiocytes become free macrophages. Polymorphonuclear leukocytes can also be can also do the function of protection. Age changes of the pulp tissue. Due to continuous deposition of dentine, the pulp chamber becomes smaller with age. And this is not uniform throughout the coronal pulp, but progresses faster on the floor than on the roof or side walls. And the primary changes in aging are a reduction in volume due to continuing dentine formation throughout life, and a change in content resulting in more collagen, a reduced cellular content, and a reduced nerve supply, making the pulp less sensitive. Irregular calcifications, pulp stones, can be found but have little clinical significance except when undertaking root canal therapy. So these age changes is necessary to keep in mind if it goes about treatment of old-aged patients. So possibly it is important to remember about this peculiarity of aging of the pulp tissue, if it goes about therapy of old-aged patients. And one more important that is necessary to refresh in your mind, it is functions of pulp. So pulp has a few functions. Dentinogenic function, the most important. Odontoblasts are responsible for dentine formation and can generate a process of collagen fiber mineralization from the predentine. Sensory function. The pulp responds to injury with pain. It is one of the most important functions of the pulp. If it goes about even pulpitis. Protective function. It mobilizes defense cells when bacteria enter it. And histiocytes, macrophages, are responsible for this. Nutritive function. It provides nutrients to the odontoblasts. And reparative function. The pulp responds to insults, bacterial, iatrogenic, traumatic, by producing secondary or tertiary dentine and thus repairing itself. Definition of the term. What is pulpitis? It is inflammation of dental pulp tissue due to several reasons. Important to mention about epidemiology. So epidemiological studies report that dental caries is the most frequent etiological factor for the appearance of pulp diseases. According to the depth and extension of this, anaerobic and gram-negative microorganisms are one of the most important causes that can affect the pulp. Numerous epidemiological studies were done to find out distribution of this disease, and the age group mostly found in the study was patients older than 45 years, with a 52% involved in the pulp diseases. Among the diagnosed pulp diseases, symptomatic irreversible pulpitis, we will discuss about it later about this classification, was the most prevalent, 46%. And 26% endodontic diseases, while root resorption was the least prevalent. And here you have this distribution, less than 1% of cases. And pulpitis has such reasons. The most common cause of pulpitis is bacteria. When bacteria irritate the dental pulp through an area of tooth decay, including dental caries. Dental caries is by far the most common cause and is usually obvious unless it has extended under the edge of restoration. The pulp is involved in the inflammation process due to progression of caries lesion. In the process of destroying the tooth structure, various substances are produced that evoke inflammatory lesions upon reaching the pulp. It is important to understand that even during its initial exposure of dentine, caries evokes inflammatory responses in the pulp. Another reasons that can cause inflammation of pulp tissue: trauma, overheating of tooth tissues, and toxic influence to the pulp. So trauma. Different reasons of trauma can be: exposure during cavity preparation allows bacteria to enter the pulp and also damages it mechanically. Fracture may either open the pulp chamber or leave so thin a covering of dentine that bacteria can enter into it. A tooth, particularly a restored premolar, may split, usually under masticatory stress. And these small cracks are often invisible, but allow bacteria enter into the pulp chamber. Another reason: overheating of tooth tissues. Over rapid cavity cutting, especially of deep cavities, can cause immediate damage to the pulp. Large, unlight metal restorations may also allow continuous low-grade thermal stimuli to damage the pulp over a long period. And toxic influence. Some restorations without a protective lining, especially chemical acute composite that is placed without cement lining, particularly in the past, were sufficiently irritant to kill the pulp. Microorganisms can enter the pulp cavity into different ways. So there are so many ways by which the microorganism can reach the pulp, and it is of prime importance that we know them for our treatment planning. And the various routes by which the microorganism reach the pulp are as follows. Through dentinal tubules, through the caries cavity. After caries lesion or during dental procedures, microorganisms may use the pathway in the centripetal direction to reach the pulp. Bacteria gain access to the pulp when the dentine distance between the border of caries lesion and the pulp is 0.2 millimeters. It has long been known as the main etiologic factor in the pulpal inflammation, necrosis, periapical periodontitis, and ultimately abscess formation. Through open cavity. Direct pulp exposure of traumatic origin, such as in coronal fracture, or that of iatrogenic nature due to operative procedures, breaks the physical barrier imposed by dental structures and leaves pulp in contact with a septic oral environment. Through periodontal membrane, another possible way, periodontal membrane. Microorganisms from gingival sulcus may reach the pulp chamber through the periodontal membrane using a lateral channel of the apical foramen as a pathway. This pathway becomes available to microorganisms during a dental prophylaxis due to dental luxation and, most significantly, as a result of the migration of the epithelial insertion to the establishment of periodontal pockets. Through periodontal abscess, it is another possible way of how microorganism can enter root canal. Retrogenic pulp infection, retrogenic. Either accompanying or immediately following an acute periodontal abscess is also an infrequent cause of otherwise unexplained pulp necrosis. Bloodstream. A transient bacteremia may occur for any number of reasons during the normal day of a healthy individual. Bacteria present in the blood would be attracted to the dental pulp following trauma or operative procedure that produced inflammation without causing pulp exposure. This attraction through blood or lymph is known as anachoresis, which serves as the path for endodontic infection. And actually, when we say anachoresis, we should think that microorganisms distributed from other areas of the body into the bloodstream of the tooth. So one more reason, faulty restoration. Studies have proven that salivary contamination from the occlusal aspect can reach the periapical area in less than 6 weeks in canals obturated with gutta percha and sealer. If the temporary seal is broken, or if the tooth structure fractures before final restoration, or if the final restoration is inadequate, bacteria may gain access to the periapical tissue and result in infection. That's why it is of great importance to provide long-lasting and tight coronal restoration and extent. Microorganisms might reach the principal and or lateral canals migrating from an infected tooth to a healthy pulp as a consequence of the contiguousness of the tissues, thereby spreading the infection to adjacent area. Microorganisms. that are present, that are responsible actually for development of pulpitis. Almost 700 bacterial species can be found in the oral cavity. Once the root canal is infected coronally, infection progresses apically until bacterial products or bacteria themselves are in a position to stimulate the periapical tissues, thereby leading to apical periodontitis. Endodontic infections have a polymicrobial nature with obligate anaerobic bacteria conspicuously dominating the microbiota in primary infections. There are various microorganisms related to intraradicular and extraradicular infections, and organisms involved in persistent infection. They are as follows. Actually, this photo shows you the most typical and predominant microorganisms that can be found out inside the root canal pulp tissue inflamed due to pulpitis. So Fusobacterium, Prevotella intermedia, and Porphyromonas gingivalis. And actually here I have collected all of them in groups. I will just stop on the headings of these groups. So the most typical microorganisms, it is black pigmented gram-negative anaerobic rods, Prevotella and Porphyromonas, and their subgroups. Tanerella forsythia, previously called bacteroids. Dialister species, anaerobic gram-negative Cocobacilli, Fusobacterium, spirochetes and subgroups of spirochetes, gram-positive anaerobic rods, Actinomyces, Eubacterium, gram-positive cocci, Parvimonas, Peptostreptococcus, and subgroups of it, and by the way, Enterococcus fecalis. As well, some other bacterial species that are present in a low to moderate concentration can be Campylobacter, Veillonella, Neisseria, etc. Numerous species are responsible for pulp inflammation and can be found out during microscopic examination of pulp tissue. Pathogenesis of acute pulpitis. The progression of disease in the dental pulp is similar to changes in other connective tissues. Typically, the tissue and disease progresses through the following stages: normal, inflammation, for example, pulpitis, necrosis, infection, and loss of pulp tissue. An example, pulpless canals. Pulpitis, it is clinically determinate inflammatory responses of pulp to irritants in which exudative forces are hyperactive. Exudates increased and intrapulpal pressure, leading to pain. Vasodilatation and blood stagnation lead to release of plasma protein, which cause hypoxia and anoxia of tissues and cell death, proteolysis. There are primarily external irritants such as heat, cold, sweat, sore, and secondary internal such as dead cells and pus. And here we have this scheme of pathogenesis of acute pulpitis. So how everything starts: alteration, hypoxia, degranulation of cells, release of biologically active substances, histamine, serotonin. Next stage, exudation. We have initial stage, can be reversed. Then it progresses into pulp hyperemia, acute localized pulpitis. It is divided into serous and purulent type of inflammation and proliferation. Classification of disease. Many different classification systems have been advocated for pulp diseases. However, most of them are based on histopathological findings rather than clinical findings, which leads to confusion since there is a little correlation between them. Most classifications mix clinical and histological terms, resulting in misleading terminology and diagnosis. This in turn leads to further confusion and uncertainty in clinical practice when a rational treatment plan needs to be established in order to manage a specific pathological entity. So that's why different types of classifications were developed. A simple yet practical classification of pulp diseases, which uses terminology related to clinical findings, is proposed. And this classification will help clinicians understand the progressive nature of the pulp diseases process and direct them to the most appropriate and conservative treatment strategy for each condition. In Ukraine, we use classification of pulpitis that was proposed by dentists Yavorska and Urbanovich in 1964. And here you have this classification that we use in clinical practice in our country. According to this classification, pulpitis are divided into acute, stage chronic, and exacerbation of chronic, and as well the fourth group, it is pulpitis complicated by apical periodontitis. Acute types of pulpitis are pulp hyperemia, serous localized pulpitis, serous diffuse pulpitis, purulent and traumatic. Chronic types, fibrous, hypertrophic or pulp polyp, gangrenous, and concrementous or pulp stone. And of course, exacerbation of chronic pulpitis and pulpitis complicated by apical periodontitis. Another types of classifications that were suggested according to American Association of Endodontists, we have normal pulp, reversible pulpitis, symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis, pulp necrosis, previously treated tooth, previously initiated therapy. Actually, whenever you will look into some foreign book, English book, you will find this classification, and diseases symptoms of the disease will be explained according to this classification: irreversible pulpitis and reversible pulpitis. So Ingalls classification, another classification that can be found, and according to it we have inflammatory changes and retrogressive changes. Inflammatory changes are hyperactive pulpalgia, hypersensitivity, hyperemia. Acute pulpalgia can be incipient, moderate, advanced. Chronic pulpalgia, hyperplastic pulpitis, and pulp necrosis. And retrogressive changes, atrophic papulosis, calcific papulosis. And few more are available, but I'm not stopping on them. But still few more classifications available. It is the most used one here I have described to you. So according to American Association of Endodontists classification, we have reversible and irreversible pulpitis, and clinical manifestations of them are such. Reversible pulpitis refers to instances where the inflammation is mild and the tooth pulp remains healthy enough to save. In our Ukrainian classification, we can think that the most close to reversible pulpitis is hyperemia of pulp and localized serous pulpitis. Irreversible pulpitis. Actually, it is all types of pulpitis that are not hyperemia and localized serous pulpitis. Irreversible pulpitis occurs when inflammation and other symptoms such as pain are severe and the pulp cannot be saved. Irreversible pulpitis may lead to a type of infection called periapical abscess eventually, and this infection develops at the root of the tooth, where it causes a pocket of pus to form. So irreversible pulpitis usually has endodontic treatment. Basically, they classify it according to this. Reversible pulpitis means that these tooths will have treatment without root canal therapy, preserving the pulp integrity. Irreversible pulpitis means that treatment for these groups, for this disease, will be endodontic treatment of root canals. So basically, they classify according to the treatment strategies, but not to the clinical findings and in our Ukrainian classification. Okay, so clinical manifestation. So we move to clinical manifestation of pulpitis. Diseases of the pulp tissues are dynamic and progressive in nature. Each disease condition may progress to other conditions if left untreated. Hence, the signs and symptoms will vary depending on the stage of the disease at the time the patient presents for the treatment. In addition, the reaction to and the perception of pain will vary between individual patients and is influenced by the individual's emotional status and the coping strategies used to manage the pain. Many of the signs and symptoms overlap between the various pulp conditions due to the dynamic interactions and the progressive nature of the disease process. Therefore, the following descriptions of pulp diseases are based on the typical presenting complaints and clinical findings. When making a diagnosis, clinicians should be aware of the dynamic nature of the pulp disease process, whilst also taking into consideration the limitations of assessing the true state of the pulp's blood supply with current pulp testing and examination techniques. Main symptoms of pulpitis can be grouped, and they are as follows. Attacks of sharp, spontaneous pain with irradiation following nerve trigeminal that is usually increased at night when patient is laying down. Pain is provoked by temperature, chemical or mechanical stimuli. A duration of pain is usually long-lasting. It lasts few minutes after stimulus stops its action. For opposite to caries, pain stops immediately after elimination of irritant. Next, it is presence of short periods without pain, so-called light periods. Attacks of pain could be short with long light periods or long periods of pain attack with short light periods. Actually, light periods, it is period without pain, depending from the level of pulp inflammation. Purulent inflammation of pulp is accompanied by constant throbbing pain without light periods. Pain can calm down by rinsing oral cavity with cold water. It is a pathognomic symptom of purulent inflammation. Pain can be calmed down by rinsing of oral cavity with a cold water. A little bit calmed down. And next, it is pain could be localized in some stages of pulpitis. Pain could be localized or irradiate following nerve trigeminal branches. So these are the main symptoms of pulpitis. And now, one by one, we will discuss all types of acute pulpitis. And we will start from pulp hyperemia, as it is the initial inflammation of the pulp tissue. When it goes about describing any of the disease, we need to specify the complaints of the patient, objective examination, of the infected area, to provide some diagnostic criteria and give diseases for differential diagnosis. So, complaints of the patient in the case of pulp hyperemia are acute spontaneous pain in affected tooth that lasts 1-2 minutes, light periods without pain, from 6 till 24 hours. Pain attacks are increased at night. Pain arises from all kinds of stimuli and lasts for 1-2 minutes after their removal, and there is no irradiation of pain in this case of pulp hyperemia. So patient can clearly indicate which tooth causing pain, discomfort for the patient. Objective examination. Caries cavity is medium or deep. Amount of decay dentine is in correspondence to the course of caries. Probing is painful in a limited part of caries cavity bottom. Pain in a few minutes disappears. Vertical percussion is painless. Temperature test, applying of cold or hot, gives such results. Pain from cold water that can last for 1-2 minutes. And diagnosis. Diagnosis for all pulp diseases can be done due to clinical signs and symptoms of a certain disease, results of extra methods of examination such as temperature test, electric pulp test. X-ray data actually doubtfully, but we can use X-ray data just to check the proximity to the pulp tissue. If it is deep caries cavity and dentist is not sure about the reason of pain, X-ray can only show the proximity to the pulp chamber, but it is not effective in diagnosing processes. So the main diagnostic methods, it is clinical signs and symptoms and results of temperature test and electric pulp test. Differential diagnosis of pulp hyperemia is done with acute limited pulpitis and acute deep dental caries. So this table shows you a differential diagnosis of pulp hyperemia. We can provide differential diagnosis using such criteria: duration of pain attack, probing of caries cavity bottom, and electric pulp test. So in the case of deep dental caries, pain is short-term pain that is immediately stopped when irritant stops its action. Probing of caries cavity bottom is slightly painful because there is a proximity to the pulp tissue. And electric pulp test gives a result of 8-10 microamperes. In the case of pulp hyperemia, there will be spontaneous pain, and actually it is the new characteristic of pain in the case of inflammation of pulp: spontaneous pain, sharp attack, irradiation. So in the case of pulp hyperemia, will be spontaneous pain and pain due to temperature and mechanical irritant that lasts for a few minutes, as you can see, 1 to 3 minutes, few minutes actually. Probing, painful in a limited part of a caries cavity bottom, but painful. The results of electric pulp test: 10-20 microampere, 10-12 microamperes, excuse me. Acute localized pulpitis, for opposite to pulp hyperemia, will have longer period of pain attack, 5-10 minutes. But pain is the same will arise spontaneously or due to different stimulus. Duration of pain from 5 till 15 minutes. And light periods, periods without pain, has a duration of 2, 3 till 5 hours. Probing of caries cavity bottom is sharply painful in the projections of pulp horns. We have one more characteristic: painful probing in the projections of pulp horns, and increased decreased electric pulp stimulation, 15-20 microamperes. The next disease, it is acute serous localized pulpitis. Complaints of the patient: acute spontaneous throbbing pain that lasts 5-10 minutes, light periods from 2 hours and more. Pain attacks are increased at night. New characteristic that you can find in this disease: night pain. Pain arises from all kinds of stimuli, slowly disappears after their removal, sometimes could irradiate in adjacent teeth. So here we have irradiation of pain, and patient cannot clearly indicate which tooth causing discomfort for them. Objective examination. Deep caries cavity with great amount of decayed dentine. Probing is sharply painful in one point. Pain is present for some time after probing is stopped. Vertical percussion is painless. Temperature test: pain from cold or hot water that lasts for some time after irritant is removed. Diagnosis, the same. Diagnosis can be set due to clinical signs and symptoms, result of temperature test and electric pulp test. Differential diagnosis is done with pulp hyperemia and acute serous localized pulpitis. Acute serous diffuse pulpitis. Complaints: sharp, spontaneous, attack-like pain from 2 hours and more. As you can see, inflammation progress and complaints of the patient worsen from hyperemia till serous diffuse pulpitis. We have progression of inflammation, and thus pain syndrome is severe. Light periods decreased, only 10-30 minutes. Pain attacks are increased at night, arises from all types of stimuli, especially in a laying position. Irradiation of pain following branches of nerve trigeminal. That's why patient cannot indicate which tooth is painful. It seems to the patient that all teeth cause discomfort, cause pain to them. Objective examination. Deep caries cavity with great amount of decayed dentine. All bottom of caries cavity is painful during probing. Pain that is present after probing is stopped soon. Vertical percussion can be painful, or in some cases can be painless. It depends from the person, from the patient, and from its personal response to pain sensitivity. Temperature test. Usually pain due to cold or hot water. Pain irradiates following branches of nerve trigeminal. Electric pulp test, 20-35 microamperes, decreased. General condition of the patient can worsen as well. The patients could feel headache and weakness and fatigue as well. Diagnosis is set due to same clinical signs and symptoms, results of temperature test and electric pulp test. Differential diagnosis for acute serous diffuse pulpitis is done with pulp stone, acute or exacerbation of chronic apical periodontitis, acute maxillary sinusitis, neuralgia of trigeminal nerve. And one by one, we will differentiate all these diseases, and we will find out what is different with acute serous diffuse pulpitis and other diseases. The first one is pulp stone. It is chronic pulpitis. First of all, character of pain. The same as in acute serous diffuse pulpitis, arise spontaneously at night when body is in supine position or movement. Similar. Provoking factors of pain: changing the position of body up and down, and checking tooth by percussion. Additional clinical signs. Can be visible attrition or abrasion of tooth crown. X-ray data reveal presence of denticle, pulp stone. It is different from the acute serous diffuse pulpitis. It is only typical for pulp stone, this presentation. And the general state of the patient's health is not disturbed. Patient can normally live with this disease for a long time as it do not severely disturb him. But in the case of acute serous diffuse pulpitis, inflammation will increase and progress and leading to constant pain. In the case of pulp stone, the pain will be only from these provoking factors, moving up and down or taking the laying position. The next disease that we should differentiate acute serous diffuse pulpitis was acute or exacerbation of chronic apical periodontitis. Character of pain: constant, dull pain, increased during biting. It is something different because in the case of pulpitis, pain do not increase from biting. It increases from some temperature stimuli, chemical stimulation, but it can be spontaneous. Usually it is spontaneous, but can be increased from some stimulation. In the case of apical periodontitis, spontaneous pain is not typical, but pain from biting, from tapping on a tooth. So it is different. That is only typical for apical periodontitis, acute exacerbation stage. Provoking factors of pain: mastication and biting on the tooth. One more, different. And additional clinical signs: probing of caries cavity bottom is painless. In the case of pulpitis, always painful. Tooth cavity is disclosed. Percussion causes sharp pain. Pulpitis can be present or can be absent. Mucobuccal fold is swollen and hyperemic near causative tooth. In the case of pulpitis, there is no changes in mucobuccal fold. Gums are normal. General state of patient's health: headache, weakness, loss of appetite, a rise of temperature is possible. So in pulpitis, possible, but not obligatory. In the case of acute exacerbation of chronic apical periodontitis, these general symptoms always is present and they are obligatory. Another disease that we need to differentiate acute serous diffuse pulpitis was acute maxillary sinusitis. In the case of sinusitis, pain is constant, dull, and throbbing in the maxilla, increases when head is bowed down. It is typical pathognomic symptom for sinusitis. It is not typical for pulpitis. Provoking factors of pain: any irritants don't initiate or relieve pain. Pain could start when biting on teeth that are localized close to the inflamed part of the maxillary sinus. Additional clinical signs: feeling of nasal congestion, difficulty of nasal breathing through appropriate half of nose, mucus or pus discharge from nose. General state of patient's health: increase of temperature of the body, total weakness, headache that increases during cough, sneezing, a tilting of the head, and quick fatigue. The general symptoms is obligatory and they are present. Okay, so it was differential diagnosis of acute serous diffuse pulpitis with different diseases. And one more, neuralgia of nerve trigeminal. In the case of nerve trigeminal, pain will be throbbing, exhausting, that appears and disappears spontaneously. Provoking factors: mechanical and temperature stimuli that do its action in triggering zones. Actually, triggers. It is important in neuralgia. Okay, additional clinical signs. It will be hyperemia of face, tearing, increase of salivation, reflector contraction of chewing muscles. In a case of pulpitis, it is never present. So it is only typical for nevralgia, nephritis. General state of the patient's health. General state of organism is not changed, but during attack of pain, patient freezes in troubled pose and afraid to move because any movement will cause severe pain. That's why patient try not to move, not to cause pain for themselves if they feel that this attack of pain starts. And one more, I will stress your attention at triggers. Triggers is important in detecting neuralgia of nerve trigeminal. So we have successfully moved to acute purulent pulpitis. Suppurative inflammation. In the case of this disease, a patient presents with complaints on a spontaneous, throbbing, continuous pain that could be weakened for a few minutes, not stopped, but weakened only by taking cold water. In this disease, there is irradiation of pain. Pain is exacerbating at night and from hot stimulus. A relieving factor is cold water. Any of the irritants lead to sharp attack of pain. Objective examination. Deep carious cavity with great amount of decayed dentine. Sharply painful probing of all carious cavity bottom, roof of the pulp chamber could be easily perforated and drop of pus could come out. Vertical percussion is painful. Cold water relieve pain for few minutes. Electric pulp test 35-45 microamperes. Actually, percussion in a case of suppurulent inflammation is extremely painful because exudat, suppurative exudat, press on nerve endings, and thus there is a pain during percussion. Diagnosis can be set due to same data: clinical signs, symptoms, results of temperature test, electric pulp test. Differential diagnosis is done with acute serous diffuse pulpitis, acute exacerbation of chronic apical periodontitis, acute maxillary sinusitis, and neuralgia of nerve trigeminal. I will not stop on these differential diagnosis diseases because we have discussed them before. And I'm moving to another disease. It is traumatic pulpitis. So acute traumatic pulpitis could be due to few reasons, and they are as follows. First of all, accidental exposure of pulp. Quite often, this happens in the case of careless preparation of the carious cavity or when removing the layer of demineralized dentine with an excavator. A sign of pulp exposure is a drop-shaped hole. Pink pulp is visible through the perforated area of dentine. Probing of it is very painful, and therefore it is not recommended to touch the pulp by the probe because it will cause severe attack of pain. Accidental injury of the pulp. Accidental injury of the pulp, another reason for traumatic pulpitis. The reason is a penetration of the pulp tissue by instrument. In such cases, the pulp is always infected with necrotic dentine because instrument was with necrotic tissues. The first sign is acute short pain. Objectively, at the bottom of the caries cavity, in accordance with the exposed area, an exposed wounded pink pulp is visible, as you can see on this photo. A drop of serous bloody fluid comes out through the perforated area. Actually, this photo can show the pulpotomy procedure for several teeth with the biodentine. Next reason for traumatic pulpitis, it is exposing the pulp in a case of fracture of the tooth crown. Such a clinical picture is usually possible due to acute trauma. The fracture line of the tooth crown can pass through the level of the tooth cavity, along the equator, in the neck, and so on. In such cases, the pulp tissue is significantly exposed, quickly infected. The patient suffers from pain from various external stimuli. Even air movement can cause severe attack of pain. So such fracture of the tooth crown can be by habitual trauma. Falling down, for example. Okay, so we have discussed all clinical signs and symptoms of different types of acute pulpitis. And now I just want to stop at diagnosing, few points about diagnosing of this disease. So clinician's ability to diagnose accurately is dependent on having a thorough understanding of the disease process involved, as well as having a thorough understanding of the diagnostic procedures and tests being used and their limitations. So it is important to understand and keep in mind. So diagnosis of pulpitis is based on clinical findings, results of pulp vitality tests, and possibly X-ray. But once again, I'm stressing your attention that X-ray will only show the anatomy of the pulp chamber and possibly can show proximity to the pulp tissue, to the possible exposure of pulp tissue in a case if it is long-lasting carious lesion, or if it is old long-lasting restoration with a cracked margins and so on, and possibly the patient present with typical complaints for pulpitis, and dentist just cannot suggest which tooth, because there are few teeth. Patient possibly could have few teeth with a similar clinical picture, and X-ray will show the anatomical state of the pulp chamber. So in this case, we can say about X-ray, but actually X-ray cannot be used as a diagnosing data for diagnosing criteria for pulpitis. It will show anything, because what is pulpitis? It is inflammation of soft tissue, and it is impossible to see inflammation of soft connective tissue on X-ray. Only it can show the anatomy of the pulp chamber and possible exposure of it. Next statement. A dentist can diagnose pulpitis from a person's symptoms and examination of the teeth and possibly X-rays. In some cases, the dentist may perform other tests, such as sensitivity test. The test will check to see if cold or hot stimuli cause pain and discomfort. Okay, I need to connect charger. Excuse me. So sensitivity test, tooth tap test. The dentist taps gently on the tooth with a lightweight instrument to check the level of inflammation, electric pulp test. The dentist may use a tool to deliver a small electrical charge to the pulp. If the person can feel the charge, the pulp is responding normally and the pulpitis may be reversible. So these tests can help the dentist to determine the extent of the damage and possibly save the pulp. And in a brief, let's revise these extra methods of examination. So sensitivity to cold, that can be used to check the vitality of pulp tissue. In a cold test, the cold object is placed on the crown of the tooth near the gingival margin for best performance. Several teeth must be tested for proper reference. The cold test can be performed with an ice stick, as in the picture, ethyl chloride, or a frozen carbon dioxide, dry ice. The ice stick is not very effective, but it is probably the most widely used. Carbon dioxide has been shown to be effective even in teeth with crowns. A negative response to cold may be an indication of pulpal necrosis, but this is also influenced by other factors, such as the amount of secondary dentine. Sensitivity to percussion. So tenderness to percussion is tested both vertically and horizontally. In the case of pulpitis, we use vertical percussion. Horizontal will be more used if it goes about apical periodontitis or periodontal disease. So several teeth must be tested in random order to get an understanding of how the patient reacts. A mirror handle is used with only slight force to try to elicit a possible reaction from the patient. Sensitivity to vertical percussion is a sign of apical inflammation that is typically caused by acute apical periodontitis, but may also be caused by occlusal interference, vertical root fracture, and rarely also by pulpitis. Rarely, but can be. A negative test result does not necessarily mean the absence of inflammation. Sensitivity to horizontal percussion can be caused by marginal periodontitis, lateral periodontitis, or vertical root fracture. However, the results of percussion tests must always be interpreted with caution. So I will summarize about percussion. So in the case of pulpitis, sensitivity possibly can be present due to vertical percussion if exudates press on the nerve endings. So possibly can be present in pulpitis, but mainly sensitivity to percussion is typical for apical periodontitis and marginal periodontitis if it goes about horizontal percussion. Next strategy, it is electric pulp testing. Electric current from a pulp tester is used to stimulate pulpal sensory nerve endings. Myelinated A delta fibers near the pulp dentine body react to this stimulation rather than C fibers. And here you have this device, electric pulp tester, with a tip, the special wire that is placed closely to the lip, or the patient can keep it in his hands. And the tip of this device should be placed to the cusp or to the cutting edge of the tooth, and then current stimulation is done. Actually, technique is described here. So the tooth and its surroundings are air dried and isolated from neighboring teeth with plastic strips if large metal fillings are present. The pulp tester tip is placed in the incisal edge cusp tip area with a small amount of electrolyte paste. The number of nerve endings is usually greatest at areas corresponding to cusps. That's why cusps we choose for this. In most models, the circuit must be closed by a lip electrode of the patient touching the metal part of the pulp tester. The patient is asked to signal when he or she feels a sensation of tingling. Actually, yes, the patient should be warned that whenever he or she feel some pain sensation, it should signal to the doctor and stimulation should be stopped. When carefully used, the electric pulp test is a valuable diagnostic tool. However, it must be understood that a positive response indicates the presence of nerve activity in the pulp, but does not allow detailed analysis of the pulpal status. It is important to memorize. Similarly, a negative response indicates pulpal necrosis, but due to great anatomic variation, the possibility of a false negative result must always be considered. Testing several tests for the same patient helps to improve the reliability of the test. And some key points about X-ray diagnosis, why it is possibly can be used. So X-ray, radiographic examination may provide information about the presence of interproximal caries that are not visible on intraoral clinical examination and of caries underneath and alt restorations close to a pulp horn. It is important. Next, the periapical zone usually appears intact, periapical. At most, it may present a slight widening of the space of the periodontal ligament. And this is true when it goes about chronic types of pulpitis, those that have long period of, they last for a long period of time. Possibly for this case will be a little bit widening of the periodontal space of the periodontal ligament. The presence of early resorption of the bony trabecula close to the apex is the exception and certainly not the rule. Furthermore, it is not necessarily accompanied by symptoms of pulpitis. And finally, in the earliest phases of pulpitis, the patient's response to the clinical examination and the various tests may not be very helpful in reaching the correct diagnosis. As well, necessary to memorize this statement. And finally, in conclusion, it is worth to say that thoroughly collected anamnesis, proper maintained main and extra methods of examination can help in setting a correct diagnosis. Accurate diagnosis through clinical and radiographic evaluations, pulp vitality test, and sensitivity test will suggest proper treatment for the affected tooth. References or further reading, and I encourage you to actually read these books because you can find useful information. Ingalls Endodontics, Principles and Practice of Endodontics, Mahmoud Turabinejad, Textbook of Endodontology, and finally Cohen's Pathways of the Pulp. All of that book are available and online for free. Okay, so thank you for attention and have a good day.